Welcome back, students, to this explainer and part 37 of our IPDRG masterclass. We are continuing to decode the fascinating world of healthcare coding today. I'm your lead instructor, and we're tackling a really critical area of inpatient documentation, one that frequently trips up even seasoned coders. We're diving into the ICD-10 PCS ancillary sections, specifically covering imaging, radiation therapy, and rehabilitation. But before we really get rolling today, I just have a quick favor to ask. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Your support is absolutely crucial because it helps us keep this rigorous training completely free and accessible to coders everywhere. Okay, let's do a quick recap. In our last lesson, you might remember we mastered the medical and surgical codes for the genitourinary and renal systems. We looked at some pretty complex procedures, right? Things like nephrectomies and dialysis access. But today, we're pivoting to completely new territory. We are officially leaving the operating room and heading straight into the specialized diagnostic and therapeutic departments of the hospital. Here is a quick look at our agenda for today. We'll start with an ancillary rules overview, then jump into imaging and nuclear medicine, followed by radiation therapy, physical rehab, and we'll wrap it all up with a summary and a teaser for part 38. All right, let's kick things off with section 1, an overview of our ancillary coding rules. So the very first thing you need to know is that the first character of our code completely changes based on the department we're in. B is for imaging, C is for nuclear medicine, D stands for radiation therapy, and F is for physical rehabilitation. It's actually a brilliant system because just by looking at that very first alphanumeric character, you instantly know the exact nature of the procedure being performed. Now, what is truly fascinating here is the paradigm shift in our 7-character blueprint. In section 0, which, we spent so much time on, character 3 is always the root operation. We're talking excision, resection, bypass, things like that. But in these ancillary sections, that third character becomes the root type or modality. So the focus shifts entirely from what the surgeon is doing with their scalpel to the specific type of technological equipment or therapeutic method the clinician is actually utilizing. Moving right along to section 2, imaging and nuclear medicine, which covers sections B and C. Let's look at the structure here. Notice how the 7-character rule remains completely steadfast, but the definitions of those characters adapt. In section B for imaging, character 5 now defines the contrast used rather than the surgical approach. And honestly, this makes perfect sense clinically, because in an X-ray or an MRI, whether the procedure is unenhanced or uses high or low osmolar contrast, that is a primary driver of the clinical data. These right here are your foundational root types for section B. A 0 gives you plain radiography. A 1 indicates fluoroscopy. A 2 is your CT scan. And a 3 is an MRI. You just lock these into that crucial third character position, and it clearly specifies the exact imaging modality the physician ordered. The crucial point to understand here is comparing how section B handles additives versus section C. So section B uses that 5th character to report high or low osmolar contrast media, like an iodine dye that's injected to really highlight those organs. Meanwhile, section C, which is nuclear medicine, introduces radioactive isotopes into the patient. Here, the 5th character identifies specific radionuclides, like fluorine-18 or iodine-131, and these are used to assess metabolic function or literally treat pathology from the inside out. Let's reverse engineer this with a clinical vignette straight from our textbook sources. Imagine an 83-year-old male with dyspnea, which is shortness of breath, and he gets a PET scan of the lungs and bronchi using fluorine-18. Well, this maps perfectly to code CB32KZZ. Let's break it down. C for nuclear medicine, B for the respiratory system, 3 for the root type, which is our PET imaging, 2 for the specific body part, which is lungs and bronchi, K representing the radionucleophile fluorine-18, followed by 2 Zs for no qualifiers. See? It's a beautifully logical system once you just know the definitions. Next up is section 3, radiation therapy modalities, or section D.
Now, brachytherapy is an incredibly high-yield term for coders. You absolutely must differentiate this internal radioactive seed placement from external beam radiation. By placing seeds directly in or near the tumor, the physician delivers a highly localized dose of radiation while strictly controlling the exposure to the surrounding healthy tissues. It's a real game changer for localized treatment.
For section D, your coding blueprint shifts yet again. In this section, you've got to capture the treatment modality in position 3. So is it beam radiation, brachytherapy, or stereotactic radiosurgery. Then position 5 captures the modality qualifier, like whether it's a high or low dose rate. Finally, position 6 captures the specific isotope utilized, such as cesium-137 or iridium-192. So let's build this code character by character from our documentation. We're translating a patient receiving stomach brachytherapy with a high-dose rate of cesium-137 directly into DDD-1197Z. That's D for radiation therapy. The second D is for the gastrointestinal system. 1 represents our brachytherapy root type. The second one specifies the stomach. 9 is our modality qualifier for high-dose rate, 7 signifies the cesium-137 isotope, and a Z closes it out, basically meaning we've got nothing else to report here.
All right, let's head over to Section 4, Physical Medicine and Rehabilitation, which is Section F.
I really want you to pay close attention to this unique blueprint. Unlike almost every other section we've studied so far, Character 2 is actually not a body system. Instead, it's a section qualifier. It divides rehabilitation, which is represented by a 0, from diagnostic audiology, represented by a 1. Character 4 then becomes the body system and region, and Character 6 identifies any specific equipment used. Let's see how this builds your clinical abstraction skills. You have to carefully read the clinician's notes to divide root types into either an assessment, like evaluating a patient's speech, or a direct treatment, like actively performing motor function exercises. A good rule of thumb? If a physical therapist only evaluates a patient, it's an assessment. If they intervene to actually improve a function, you've got a treatment. These right here are the heavy hitters. You will see these constantly in inpatient rehab documentation. Modalities like motor function, gait training, speech therapy, and cognitive retraining are precisely captured within that 5th character position, which is known as the type qualifier. Let's look at one more clinical vignette. A patient is admitted after a stroke with right-sided hemiplegia, which is paralysis, and a certified physical therapist performs functional ambulation. This translates seamlessly to F07Z9ZZ. That's F for physical rehab, 0 for the rehab section qualifier, 7 for motor treatment, Z for no specific body region, 9 for the gait training type qualifier, and 2 Z's for no specific equipment or further qualifiers. We've covered a lot of ground today, so let's move to Section 5, our summary, and a quick teaser for Part 38. By now, you have the exact blueprint to confidently navigate outside the medical surgical tables. The core takeaway remains: every PCS code absolutely must have 7 characters. But, as we've clearly seen, those character definitions shift dynamically in the ancillary sections to capture precise modalities, contrasts, isotopes, and rehab treatments, rather than focusing on surgical approaches and devices. And this brings us to a really provocative question, one that bridges the gap between the clinical coding and the actual business of healthcare. How do these specific, highly detailed diagnosis and procedure codes actually drive inpatient grouping and reimbursement? Well, we are going to answer that exact question in Part 38, Inpatient MS-DRG Structure and Fundamentals, where we finally see how these codes drive hospital grouping and the revenue cycle. You won't want to miss it. Thank you so much for joining me for this masterclass explainer on ancillary sections. Keep practicing those coding scenarios, and as always, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you in Part 38.